Welcome back to our second part of endocrine pathology, and we're going to start this with thyroid neoplasms. So let's talk now about thyroid neoplasms. Most of these are going to present as nodules. So what happens is the person gets these little tiny lumps or bumps on their thyroid. And so these nodules are very common. And of course, most of these are benign. And thyroid carcinoma is uncommon, which of course is a good thing. So if you look at the incidence of carcinoma versus adenoma, you can see carcinoma is going to happen much less often than an adenoma. Now what happens is the person, if they have a nodule, the doctor's going to go in and do a fine needle aspiration, and they put the needle in and they're able to take some tissue out, and so it's basically a biopsy. And so you're looking to see, does the person have any type of cancer, or is this just thyroiditis where there's swelling going on? And by the way, all of these little purplish black dots, these are immune cells in the thyroid gland causing these swellings. Now, some people believe that thyroiditis can be also treated with nutrition, and having an anti-inflammatory diet can take down the inflammation of the thyroiditis as well. We're going to watch a video now for a couple of minutes of a fine needle biopsy that's being done of a thyroid nodule.
Stay home and have a good time in life. Until that the Grim Reaper takes you.
How do you know you're even on it? You don't know.
I don't know. I'm just guessing.
I'm gonna look.
Take a look where she knows she's too high, too low. And go. Angle it a little bit. Let me see my hand. Seeing your hand.
Okay. Right here.
A little burning from the nose. Where's it?
We're not even on it.
Get a picture with her with the. You got it?
Okay, good. Yeah, you go up and down a little bit.
All right.
Awesome.
You could probably
Thank you.
needle.
So in that fine needle aspiration, what they were doing was they were removing some of the cells so that they can now test for cancer. So the thyroid adenoma is going to be the most common type. Most patients are euthyroid. They don't have hyper or hypo symptoms, although some can be hyperthyroid. Another test is a radioactive iodine uptake test, and this is where the person is given radioactive iodine by IV, and most adenomas are what we call cold. So once you take a picture of this, what you're going to see is the thyroid nodules don't absorb the radioiodine. That's why they're called cold, and they have a 5% risk of being cancerous. And approximately 95% of the thyroid nodules are going to be cold. And this shows you thyroid adenoma. And again, you can see the changes in the cells of the thyroid. This is the capsule of the thyroid here, and then these are the thyroid cells, and you can see these cells are very confused now, not appropriate thyroid cells. With a thyroid adenoma, they usually take the thyroid out, but the question is why if it's benign, and they need to see the whole tumor to make sure that it's not a carcinoma. So thyroid carcinomas, you have papillary, follicular, medullary, and anaplastic carcinomas. And so you can see the different incidence of the different types of thyroid carcinomas. Papillary is going to be the most likely to have. And a papillary thyroid carcinoma, being the most common, also is the best prognosis. And interestingly enough, you get what they call orphan Annie tumors within this carcinoma. This is papillary thyroid carcinoma. And again. And you can see the massive changes in thyroid tissue here. Now, the reason they call this orphan Annie tumor is, one, it affects younger women, and it tends to stay around for years without getting any bigger, okay, because orphan Annie, she never grows up. Usually well behaved, seldom kills people, has nuclei that represents or resembles orphan Annie's eyes, you know, how they're hollow from the cartoons like that. And it has samoma bodies, and in Greek samoma means sand, and orphan Annie's dog was Sandy. Now, by the way, let's go back. Let me see if I can show you these a little bit. So you see how you have these little areas here that are just hollow, and so that's supposed to represent like her eyes. So follicular is the second most common, a good prognosis. It's a little bit of papillary and follicular carcinoma in the thyroid. So which one would you say is the follicular carcinoma? If you say the right, you'd be correct. Medullary thyroid carcinoma is very rare. It's an endocrine tumor, not good prognosis. Anaplastic thyroid carcinoma is also very rare. It grows very fast. It's metastatic, and it invades surrounding tissues. Very bad prognosis. All right, so let's talk about adrenal pathologies. And again, a lot of this is about too much or too little. You know that the adrenal glands sit above the kidneys. They weigh about 4 grams each. They have a cortex and a medulla. The cortex is made up of 3 zones. If you look here, here are the kidneys, and here is the adrenal gland sitting above each kidney here. And you have the cortex. And the outermost layer closest to the capsule is called the zona glomerulosa. And then you have the fasciculata, then you have the reticularis, and then you have the medulla. Now the medulla is where we're going to be secreting epinephrine and norepinephrine from. So again, glomerulosa, fasciculata, reticularis. Or we can call it salt, sugar, sex. The deeper you go, the sweeter it gets. Or sometimes I've heard it called salty sweet sex. So the glomerulosa is actually secreting hormones that control salt in the body. Fasciculata is secreting hormones that control the sugar. Reticularis are the sex hormones. So glomerulosa would be secreting, for instance, like aldosterone. Fasciculata would be secreting the glucocorticoids, which, by the way, aldosterone is a mineral corticoid. Fasciculata is secreting the glucocorticoids like cortisol that helps regulate sugar. Reticularis is secreting, for instance, estrogen, progesterone, testosterone, all of those. By the way, you might remember it as like GFR, glomerular filtration rate, from the kidneys. Glomerulosa, fasciculata, reticularis. The next disease we're going to talk about is called Cushing syndrome, and this is where the person produces too many glucocorticoids. So glucocorticoids would include, for instance, cortisol. And the causes would be, first of all, you may not have to produce too many because, well, I have something else wrong with me, and now I have to actually take glucocorticoids for whatever my issue is. So I ingest steroids. Maybe I have an adrenal adenoma or a pituitary adenoma or something called paraneoplastic syndrome. Now, just paraneoplastic syndrome, to let you know, disease or symptom that is the consequence of the presence of cancer in the body, but it's not due to the local presence of cancer cells. Now, basically what that is these phenomena are mediated by humoral factors excreted by tumors or by an immune response against the tumor. So basically, I can have a tumor somewhere that has nothing to do with my adrenal glands, but that tumor is producing glucocorticoids. And so I can have Cushing syndrome because of this other tumor that's someplace else in the body. Now, the symptoms of Cushing syndrome would be hypertension, weight gain, glucose intolerance, aches in the bones, and because of cortisol being in high concentrations, or these glucocorticoids in high concentrations, cortisol has a tendency to be able to move fat around in the body. And one of the things that we see with people who have Cushing syndrome is that they have these really thin arms and legs per se, and this very round, fatter body. And a lot of the fat will go in between the shoulders, and you get what we call a buffalo hump. And then fat also goes into the face and makes the face very round, and you get a moon face, or what we used to call a moon pie face. And so with pituitary Cushing's, we have a tumor in the anterior pituitary making too much ACTH, so we produce too much cortisol. Adrenal Cushing syndrome is we have some kind of tumor in the adrenal gland and we're producing too much cortisol. And then again, that paraneoplastic syndrome, I could have, let's say, a tumor, for instance, in the lungs that then produces ACTH, and that causes me to produce too much cortisol. Or iatrogenic, which means I'm taking steroids and now I'm creating a Cushing-like syndrome from the steroids themselves. And this is a woman who has Cushing syndrome, and you can see how the body fat very much in the stomach. She's got that buffalo hump going on there, and then a very round face. And then also there's a tendency to have more hair on the face as well. Now, Addison's is the opposite of Cushing's. This is where the person produces too little cortisol, but they also produce low mineral corticoids, or they have low aldosterone levels. And you can have primary chronic adrenal insufficiency, and this is caused sometimes by an autoimmune disease. And sometimes, which is kind of interesting, is a person can have a fall, and that fall can affect the adrenal glands also, and you can have Addison's disease. And an increase in ACTH causes increase in a chemical called melanocortin, which then can increase pigmentation in a person. So a person, let's say you have a white person who has Addison's disease, they're going to look very tan. And so they have a lot of pigmentation. So remember, the reason we're producing so much ACTH is that negative feedback thing. I'm not producing enough aldosterone, enough cortisol, and so what my body does is it causes me to produce more ACTH, and that way I now produce more pigmentation. So some of the symptoms of Addison's disease would include, first of all, a slow onset. You need to destroy about 90% of the cortex to really have this disease. And then weakness, fatigue, gastrointestinal complaints, hypotension, and then that skin hyperpigmentation. So MJ is a 33-year-old female, previously healthy, who began having symptoms of fatigue, weight loss, craving potato chips. On Wednesday, she develops a headache. On Thursday, she's very fatigued and vomiting. On Saturday, her husband brings her to the ER because she has right vision loss, and they give her IV fluids, but they're unhelpful. And now you can see her. Now, take a look at the color of her skin. And see the color of her skin? She almost looks jaundiced. She's so yellow. Compare her to her husband's skin. Sunday, she has right side paralysis. Oxygen levels are dropping. Her brain is swelling and she goes into a coma. Her blood pressure is 70/33. She's given IV fluids and put on a respirator, and she gains 40 pounds, which is all fluid weight. On Tuesday, there's no brain activities and the kidneys are shutting down, and the doctors tell her husband nothing can be done. On Thursday, she gets a different doctor. This doctor decides to give her IVs of sodium, hydrocortisone, which basically is cortisol, and dextrose. On Saturday, her eyes open. On Sunday, they remove the IVs. And the following week, they remove the feeding tube. She's able to talk and start to go through physical therapy and occupational therapy. Now, why did this happen? Well, she developed Addison's disease. And remember, Addison's disease does not allow you to produce aldosterone or the cortisols. So she's not able to keep sodium in her body, and she doesn't have enough cortisol to regulate blood pressure, to regulate the fluids of her body, and to regulate her sugars. 2 months later, she's back to work, feeling normal. Cortisol and prednisone have to be taken daily for life, and she carries a crisis kit, which includes hydrocortisone. Pheochromocytoma. This is neoplasm of the catecholamine-producing cells, which are in the medulla of the adrenal gland. Very rare, but it does cause hypertension. Then you can do a urinalysis and measure the catecholamines within the urine. And 10% tumor, 10% extra-adrenal paraganglioma, 10% bilateral, 10% familial, 10% bad. So basically, these are the chances of having these types of tumors. This is a pheochromocytoma, and this is the adrenal gland. Pheochromocytoma, and so you can see kidneys here and adrenal glands. Obviously not looking normal. And this is the adrenal gland here. Now we're going to talk about diabetes. Unfortunately, very common disease. 100 million cases worldwide. That's 3% of the world has this disease. That is huge. 13 million in the United States have it, with probably only half being diagnosed. 54,000 die in the United States each year. This is the 7th leading cause of death in the U.S. The lifetime risk of getting diabetes has gone up 5% in the last few years. A disease in which the body does not produce or properly use insulin. This is what diabetes is all about. And we have primary issues and secondary issues as far as diabetes is concerned. Those primary issues are referred to as type 1 and type 2 diabetes, and basically the end result is the same thing. You don't have enough insulin. So when we're looking at the use of insulin in the body, insulin is affecting adipose cells, it's affecting muscle, and it's affecting the liver. So if we look at adipose cells first, what insulin does for us is it increases glucose uptake in those cells. It also increases lipogenesis, and genesis means to make something, and lipo, of course, is fat, so it increases fat production in the adipose tissue, and then it decreases lipolysis. Now, lysis means to break apart, so it decreases your ability to break down fat in the adipose tissue. So basically, we take glucose, put it in the adipose tissue, we turn it into fat. In muscle, particularly skeletal muscle, and cardiac muscle too, there is an increase in glucose uptake, and what that does is it helps us to make glycogen for storage in order to be able to utilize it for energy for the muscles. Also, insulin helps in protein synthesis of those muscles, because when we use our muscle, we're breaking down muscle all the time, so we have to build muscle back up. It's just normal. In the liver, insulin decreases gluconeogenesis, and again, this is producing glucose from fat and from proteins. It increases glycogen synthesis and it increases lipogenesis. Type 1 diabetes. The problem is the beta cells. And so basically what's happening is the person doesn't have enough beta cells anymore. And there are lots of what we call susceptibility genes. One is in the MHC class 2 region. And so this type 1 diabetes is a genetic issue. And so the MHC type 2 antigens are abnormal, and so the T cells are going to attack these beta cells and destroy them. And so basically this is a genetic issue that creates an autoimmune disease, and it's a slow, persistent attack. The type 2 diabetes is we can't make enough insulin and tissue can't properly use the insulin. So there's probably some genetic factor here. There's probably some autoimmune playing in all of this. Of course, diet definitely plays in this, because we've talked about before where consuming too many carbohydrates can cause overproduction of insulin, and then when we have overproduction of insulin, we can have downregulation of the insulin receptors, so that now those receptors are on the inside of the cell, and even though we have insulin floating around in the blood, we can't get insulin binding to those receptors. So there's some deranged insulin secretion that's going on by the pancreas as well, especially if you consider that people eat a lot of carbohydrates, and you can have what we would call beta cell burnout. So you're eating carbohydrates all day long, and your glucose levels are going up and down, and you have to release tons of insulin, and so eventually those beta cells start to burn out, and you can't secrete the insulin you need. And then we talked about that downregulation of those receptors. This is what we would refer to as insulin resistance. So non-enzymatic glycosylation. Glucose attaches itself to proteins, forming what are called AGEs. These are advanced glycosylation end products. So the AGEs, they start to cross-link and they begin to trap things. And the AGEs bind to receptors, and then this happens to create nasty problems in the body. Intracellular hyperglycemia, some cells take up the glucose, now even without insulin, because there's so much glucose floating around in the blood. The glucose activates what we call protein kinase C. And protein kinase C then induces production of what we call pro-angiogenic and pro-fibroblastic molecules. And now those molecules make these types of fibers that cross-link also, and they can bind to receptors. And now your receptors can't bind what they're supposed to bind, and you do have a lot of issues throughout the body. Now, in order to measure glucose, once upon a time, what doctors used to do is they would give you what's called a glucose tolerance test. So they would measure your blood and measure your baseline glucose levels, and then they would give you glucose to drink. And they would look to see how long does the glucose levels take to rise, how long do they stay up, and how long do they come down again. They were able to tell if you had diabetes from this or not, if you were able to regulate your glucose well or not. Now, however, there is an awesome test called your hemoglobin A1C test. So you can take this blood test, and you don't even have to be fasting for this, although it's probably better to be fasting. But what this does is it looks at the levels of glucose in your blood for the past 3 months. And what we find is that glucose has the ability to bind to hemoglobin. And the more glucose in the system, the more the glucose binds to hemoglobin. It changes the shape of the hemoglobin, and you get what we now refer to as hemoglobin A1C. So you want your hemoglobin A1C levels to be 6 or below. And when you look at that, you can see that the hemoglobin is below 100. But as your A1C levels go up, it shows the amount of blood sugar over the past 3 months. And of course, these levels are far too high. And when that happens, you now can diagnose your patient as having diabetes. So complications from diabetes: increased infection, microangiopathy, retinopathy, nephropathy, and neuropathy. So with increased infections, one of the things we see is you have candidiasis in the mouth, and in the female, in the vaginal area, a lot. And so you have what we would call yeast infections. Also, we have these over occurring again and again otitis externa, which is an outer ear infection. And so this is just a picture of oral yeast infection. Now, these yeast infections can become so bad that it can actually clog somebody's throat up, and they have a very difficult time eating. And then this is the malignant otitis externa. Microangiopathy is where you have accelerated, very severe atherosclerosis. And that atherosclerosis is not just in the coronary arteries of the heart. You can have atherosclerosis anywhere, and that is why you have people who will have to have a foot removed because they now have atherosclerosis in the foot. Now, the other thing also that happens when you have this accelerated atherosclerosis is that you start to have increased permeability in the blood vessels, and so there's a lot of swelling into the tissues. And this just shows you atherosclerosis in the aorta. And of course, coronary vessels. And this would be the vascular issues from the atherosclerosis in the legs and the feet. Not enough blood flow is going to cause necrosis. And then, of course, retinopathy can happen. And so, okay, just to go through this just a little bit, you have the optic disc, and then you have the macula, which is where we're going to have our increased number of cones to see good, clear, concise color vision. It also allows us to see directly in front of us. And then what happens is we don't have good blood flow. And so you have this retinopathy, and you have little hemorrhages in the blood vessels, and those hemorrhages can bleed into the macula. You can have an opening in the optic disc area, and even in this picture, it's showing you some aneurysms that can occur. And of course, this leads to blindness. And you have from this macular degeneration. And then neuropathy, you have what's referred to as peripheral neuropathy. And this, well, let me go back just real quick. This neuropathy is where the excess sugar, of course, all of these are happening, the increased infection, the retinopathy, all of this is due to the excess amounts of sugar in the blood, even the atherosclerosis. Sorry about that, you might have heard a dog barking. That's my new puppy. His name is Max, and he is a doll. Anyway, we were talking about this peripheral neuropathy, and because of these high levels of sugar, what happens is we have damage to teeny tiny nerves in the hands and in the feet especially, and that causes tremendous amounts of pain, and it can also cause the person to have numbness, tingling sensations, and once those nerves are destroyed, it is nearly impossible at this point to stop that constant pain without medication. Then we also have nephropathy, which is going to be destruction of the kidneys. And so you can have glomerular lesions, vascular lesions, or even pyelonephritis, which is where you have these urinary tract infections that can then turn into kidney infections, and it can affect one of the kidneys or even both of the kidneys. And this shows you glomerular lesions right in this region here versus a normal glomerulus. And this is a fungal bladder infection. Of course, you can see all of the infection in there. And then that concludes our endocrine pathology video for today. I hope you have learned a lot. See you next time.